Hello everyone, we are Team Mythos from Binus University, Indonesia, presenting Unmasking the Emergency First Penalty. Let's start with something counterintuitive. If you look at the raw citywide data, it actually looks like the clinic first patient have longer health journey than the ED first patient. At the first glance, you might conclude that ED is more efficient entry point. But this is a textbook case of Simpson's paradox, where an aggregate trend completely reverses when you look at the subgroups properly. Here's why the aggregate is misleading. Clinic first average are inflated by patients who have been actively managing chronic conditions for years, diabetes, hypertension, cardiovascular disease. Meanwhile, the ED first average are pulled down by quick resolution acute cases that resolve fast and disappear from the data. Once we control for the same conditions, comparing the ED first versus clinic first patients with identical diagnosis, the story flips entirely. Look at the top 20 diagnosis chart on the right. Across virtually every single diagnosis, the blue ED first bar is consistently and significantly longer than the orange clinic prior bar. This isn't coincidence, it's a pattern. The ED is not an efficient entry point for chronic disease. It just looks that way until you control what patients actually have.
So, what does the console picture actually show? Three key findings. First, divergent patient profiles. ED first patient dominate the worst outcomes. 65% in patient admission rate versus 31% for clinic first. That's more than double. And you can see this clearly in the radar chart. The red ED first profile spikes hard on inpatient admission, disease rate, and treatment length. Clinic first patients, on the other hand, show high mitral activation and frequent routine encounters, which is exactly what keeps their hospitalization and mortality low. Second, what we are calling the ED first penalty on recovery. For the exact same chronic conditions, ED first patients experience significantly longer journey days and 1.5 to 1.7 additional ED visits compared to clinic first. The city level bar chart confirms this gap holds consistently across both Topeka and Junction City. This isn't a locally anomaly. The fundamental issue is that the ED is designed to stabilize patients, not to establish a long-term disease management that chronic condition require. Third, and this is the most critical thing, 78.4% of chronic ED first patients were already active within the SVH system before their emergency visit. This is not a population of strangers walking in off the street. These are known patients with known condition and who escalated to a crisis because the system failed to intervene earlier. The pie chart makes this start. Only 21.6% were genuinely first contacts, and this is independently validated by external research. Roughly 29% of all ED visits population-wide are classified as avoidable or potentially avoidable. Our internal findings isn't an outlier. It's consistent with what's happening across healthcare system broadly.
So if the problem is clear, the aid is being used substitute for primary care by patient the system already knows. What do we want about it? Three targeted intervention. Recommendation A, targeted digital engagement for the at risk 78%. Since at first patient have significantly lower major activation at 61.7% versus 76.4% for clinic first, the gap isn't just a digital metric, it's a clinic risk factor. The external evidence here is compelling. Non-portal user are 1.92 times more likely to make an unplanned ED visit, 4.55 times more likely to have a scheduled clinic visit, and a large observational study at Kaiser Permanente for found portal access to reduce ED visit by 3.9 per 1,000 patients per month among complex chronic patients. Closing this activation gap is not an IT initiative, it's an patient safety intervention. Recommendation B, post-aid bridge clinics. Every patient discharged from the ED with a chronic condition must have a follow-up clinic visit schedule within 48 to 72 hours before they leave the building. The goal is to force the transition of care back into a proactive primary care model, converting an ED first behavior into a clinic first habit, one discharge at a time. Recommendation C, clinic routing via chronic care triage hotline for the 78% of patients who are already in the SVA system. We need to intercept them before they walk into the ED. A dedicated fast track hotline allows the clinical staff to assess the situation and route patients to an expert outpatient appointment or appropriate referral, preventing a high cost ED to stay that in most of these cases was entirely avoidable. Taken together, these three interventions address the problem at 3 points: before the visit, at discharge, and in the system workflow. That's all from us. Thank you.